Chapter 6. How is AADC deficiency diagnosed? One of the hardest things about AADC deficiency is that the main problem is in the neurotransmitter system, especially the neurotransmitter system inside the brain. Blood and urine tests can sometimes give clues, but sometimes they can also be misleading. To diagnose this condition, doctors cannot rely only on whether a child looks like the disease, and they cannot rely on one single test. First, doctors have to recognize the clinical clues: a floppy body, developmental delay, upward eye movements, body twisting after exercise, long-standing fatigue, sleep problems, nasal congestion, low blood sugar, attention and behavioral concerns. Then, genetic and metabolic testing becomes important. There are three main categories of core testing. First, CSF neurotransmitter metabolites. Second, DDC gene testing. Third, plasma AADC enzyme activity. These three types of testing are like three keys. If at least two of those keys fit, the diagnosis becomes very strong. In some situations, finding biallelic pathogenic variants in the DDC gene can establish the diagnosis, or if the CSF profile fits and AADC enzyme activity is clearly low, that can also confirm the diagnosis. The first key, the metabolic fingerprint in CSF AADC deficiency, can leave a very typical metabolic fingerprint in the cerebrospinal fluid, or CSF. You can remember it this way: the raw materials before the block go up, the products after the block go down. Because the production line is stuck, L-DOPA goes up, 5-HTP goes up, 3-OMD goes up. These are the substances stuck before the blocked step. But 5-HIAA goes down, HVA goes down, MHPG goes down. These are the breakdown products of downstream neurotransmitters. When those breakdown products are low, it suggests that the body is not making enough